Okay, so for my presentation, I did this on what is the efficacy of beginning oral baby aspirin in the first trimester for the prophylactic management of preeclampsia. So an overview of what I'll be going over is the assess, ask, acquire, appraise, apply, and secondary assess phases, and then my reference page at the end. So for the assess phase, my clinical case study scenario, Tilly, who is a 35-year-old prima gravida, presented into midwifery care at 9 weeks gestation. Based off her risk factors from the initial assessment, we found she has a history of hypertension, she's nulliparous, advanced maternal age, and has a BMI of 35. So based off her risk factors, the midwife recommends beginning oral baby aspirin starting now since she's in the first trimester to prevent the development of preeclampsia. So for the ask phase, I plugged in my question into the PICO framework. And again, my question is, what is the efficacy of beginning oral baby aspirin in the first trimester for prophylactic management of preeclampsia? So the problem are pregnant people who have high risk factors of preeclampsia, like high blood pressure, advanced maternal age, family history of preeclampsia, higher BMI, history of gestational diabetes, PCOS, or UTIs. The I, intervention, oral baby aspirin given in the first trimester of pregnancy. And then the comparison is not using oral prophylactic aspirin at all. And then the outcome, lower rates of developing preeclampsia, reduced risk of postpartum hemorrhage, reduced rates of preterm birth, reduced rates of intrauterine growth restriction. The type of question this is the therapy and diagnosis. So for the acquire phase, I was able to plug in the keywords of baby aspirin and preeclampsia and use the Boolean operator, all caps, and preeclampsia prevention. I was not able to find much by using less keywords, so that's why these were larger. I had a date range of 2020 to 2025, and I used PubMed full search. Again, my search strategy was Boolean operators, advanced search, for randomized control trials and meta-analyses. So Article 1 was a systematic review and meta-analysis. The title of this article was Aspirin Use to Prevent Preeclampsia and Related Morbidity and Mortality, Updated Evidence Report, and Systematic Review for the U.S. Preventative Services Task Force. So this specific study analyzed 23 randomized controlled trials, and it concluded evidence that showed that low-dose aspirin starting in the first trimester can reduce the risk of high-risk individuals developing preeclampsia by 15%. And they were not able to find any clinically sufficient evidence to support any adverse outcomes like postpartum hemorrhage, preterm birth, intrauterine growth restriction, intracranial bleeding of the fetus, and I was able to find that this was a high quality source. It used a large sample of randomized controlled trials, and over 6,200 pregnant people were included in this trial. The authors of this article are qualified with PhDs. They used non-bias assessments and rates of the randomized controlled trials were based on a good, fair, and poor scale system. And so that helped really show a lot of transparency. And it was also independently reviewed by 2 people. Article 2 is also a systematic review and meta-analysis, and the title of it is Aspirin Use to Prevent Preeclampsia and Related Morbidity and Mortality. So this article analyzed 28 randomized control trials. Evidence showed that more than 100 milligrams of aspirin before 16 weeks gestation was effective in reducing preeclampsia and preterm labor. It was more effective than less than 100 milligrams. And they found also no clinically sufficient evidence of adverse outcomes, the same ones that I mentioned before. I rated this as moderate quality. They did use a large sample of randomized control trials. The authors are not qualified with any PhDs or anything like that. They did use a bias risk assessment. The article is not peer-reviewed, and they also use PICO framework as well. And then my last article I used was in integrative literature. The title of this one is Effectiveness of Low-Dose Aspirin in Reducing the Risk of Preeclampsia in Women with Chronic Hypertension, an integrative review. So this found that low-dose aspirin of greater than 100 milligrams is effective in preeclampsia prevention. when adherently taken 90% of the time. The study also found that there wasn't any clinically sufficient evidence of any adverse outcomes. And this also was a high quality source. They use Whitmore and Knopfel method, and so it goes through 5 stages of problem identification, literature search, data extraction and evaluation, and data analysis and presentation findings. This really helped reduce a lot of bias, helped find any errors, and helped find um, the good pieces of evidence as well. And this source also analyzed 17 scholarly sources. So apply. And so from all of these, the evidence showed the benefit of low dose aspirin in the first trimester from 10 to 12 weeks. About 80 to 150 milligrams of the aspirin can help prevent preeclampsia. No evidence from these articles evidence from these articles showed that there is not any clinically sufficient evidence to support adverse outcomes like postpartum hemorrhage, placenta abruption, fetal intracranial bleeding, preterm birth, and intrauterine growth restriction. Baby aspirin is very affordable, so it ranges from $2 to $17, so it's not an expensive ask if people are wanting to do this. And then evidence states that low-dose aspirin is effective in preventing preeclampsia, which can reduce the rates of preterm labor, perinatal mortality, and other outcomes from preeclampsia. And then low-dose aspirin is also effective for high-risk individuals. So this includes nulliparity, preeclampsia from a previous birth, hypertension, advanced maternal age, excuse me, pregestational diabetes, twins, all these things midwives can care for. And for the secondary assess phase, what I would do is to look at the outcomes, I would monitor preeclampsia rates. So I can do this through Excel sheets. And so I can start inserting the numbers of who is taking baby aspirin, who is developing preeclampsia, who is having preterm labor, who is having postpartum hemorrhage. And so I can start putting those numbers into an Excel sheet. And so over time, I'll be able to identify, okay, what are the outcomes? Is the baby aspirin effective in reducing these numbers, or compared to the people who are not taking baby aspirin? Or am I seeing adverse outcomes? So it can really help me dial down what I'm seeing. And then here's my reference page. Thank you so much.